Okay, well, hello everyone, and welcome to the first session of a collaborative series between the South Southwest MHTTC, HHS Region 6, and the Texas Association of Community Health Centers. We are very happy to have you joining us today. So responses to the effects of trauma on human behavior and health outcomes were noted well before the landmark research study of the late 1990s through the Adverse Childhood Experiences, or ACEs study. And subsequently, SAMHSA's 2014 publication provided the framework for defining and providing trauma-informed care, or TIC. But over the years, clinicians and organizations have really grappled with turning this evidence-based practice into tangible change for the patients and staff and communities that we serve. So therefore, over the next 5 months, our team will be providing practical training and strategies for the implementation of TIC within our health centers, our behavioral health settings, and other community-based organizations represented in our session participation. And this series includes one didactic session and one open office hour per month, with the hope that you'll join us for each one of those engagements so that we can really go deeper into how this information can impact your practice and your care delivery services. So first, I'd like to introduce my colleague, Amy Rachel, who's our lead TIC clinical coordinator. Amy trained at the University of Buffalo in trauma-informed care and systems transformation. And Amy has led the development of the TACHC'S curriculum and program. And her vision and data analysis really empowers our health centers with information to improve outcomes for our patients and the staff that we work with. And I'm Aniela Brown, and I co-facilitate the TIC program with Amy and provide practical guidance and tools to help our health centers to implement and sustain their TIC transformation. I bring a community development perspective from training as a macro level social worker, as well as a Peace Corps volunteer as well. So together, our team has experience with supporting individuals, organizations, and communities as they work towards healing and resilience.
So what is trauma-informed care? Today, we're going to really kind of set the stage for us so that we're all moving forward with the same kind of definitions. We want to know that trauma is pervasive, and you may have experienced it by many of the individuals that we serve or staff, even with whom we work. Established research, scientific evidence, and publications really have demonstrated that adverse experiences in childhood and adulthood really can impact individuals and communities across the lifespan. And we can see that through physical and behavioral health manifestations, including that passage of trauma intergenerationally. So this foundational training series really provides us with knowledge about the effects of trauma and the application of trauma-informed care as an evidence-based framework that is really person-centered, strength-based, and equity-focused, which really aligns to promote healing and resilience. And you'll see here our objectives. We really today are going to define trauma, how it impacts the brain and the body. We want to discuss the relationship between traumatic experiences and potential behavioral and physical health outcomes, and then explore the utilization of trauma-informed care as a prevention framework and strategy for healing. Because we are talking about trauma, sometimes during the discussion today, some of our materials that we present may be activating for you. And so please just take care of yourself. If you need to get a drink of water, do some grounding there, just know that we're here. You can even send us a private message if you need to, but do what you need to do to take care of yourself.
So let's describe our TAC-TIC program so you know a bit where we're coming from and our organization. So TAC is the federally designated or HRSA designated primary care association for the state of Texas, and TAC assists members in providing high quality, comprehensive primary care and addressing the full spectrum of needs of our health centers so they really can focus on providing that high quality patient care. Our TAC members include federally qualified health centers, lookalikes, and other providers who strive to meet the healthcare needs of the uninsured and underinsured in our communities here in Texas. Our members operate in Texas's urban, rural, and frontier areas, all with the mission of advancing access to healthcare for all Texans.
So how did TAC come to using TIC as a framework? Back in 2018, you'll remember that across the borders of the United States, there was a time when children were being separated from their parents and being held there at the border waiting for entrance into the United States. And so our medical director and CEO here at TAC really wanted to go to provide services. So they went down to the border to do that. Our medical director by training is an internist. She was not able to give her services, but what they noticed was that people really were being impacted by this trauma that was happening. And then not only at the border, but also within our health centers and within the communities, they could see that there was this real need that we weren't prepared for what was happening. And so we needed to be able to have a response for those who would be visiting our health centers, for our staff that was working in the health centers, and then for the communities. And so as they witnessed that impact, they came back to the TAC offices here in Austin and began to do some research about what is it that we can do? And they landed on trauma-informed care. And so they began connecting with experts across the United States to find out, how do we help people manage trauma? How do we build resiliency? How do we, as a health center, take trauma that might be affecting physical and behavioral health, and how do we work with that? And so as they connected with those experts, when they actually went to the University of Buffalo, where I had studied, and had come back to Texas and was working here within a health center in North Texas. And we were able to connect and then began to build a trauma-informed care program that would be a framework for healing for our health centers, our patients, and our communities.
So throughout that process, we developed an inquiry-based curriculum, really to provide that additional education over the long term. So we have a very unique program that is learner-centered, as I said, inquiry-based, and truly transformational, with the ability to scale and spread to other sectors as well, because we know that trauma-informed care is not just our behavioral health teams, but it is our medical, but it also reaches and crosses all sectors. So health centers are taught through a train-the-trainer model via virtual and in-person sessions and coaching calls, and ongoing technical assistance to fully integrate trauma-informed care into all aspects of their health center. Cohorts are typically 5 to 10 health centers, and really that initial phase of curriculum takes approximately 10 to 12 months. And so role integration is critical from the beginning. We have 3 trainers, so from the health center, so behavioral health, a medical or dental, and then a role that is varied at the organization to really make sure that we have that integration as modeled by our health centers. Ultimately, this goal of our transformation and our program is ultimate organizational change and transformation through the use of universal trauma precautions, which we'll discuss later today. And to date, through cohorts, we have 43% of our 73 Texas health centers who have undergone this training and are currently engaged in TIC transformation. And we anticipate launching cohort 6 in January of 2024. So this program, as we described, is really built to sustain and spread and scale. So we have those trainers, we develop champion teams, and then they are then empowered with this information to go spread it throughout their departments. So really it is a slow and intentional process that we undertake with the health center staff.
So as we were developing this program back in 2019, we had several funders that we began to work with, and we began to work with the University of Texas School of Public Health to collect and analyze our data that we were gathering regarding ways in which this approach, the curriculum, the training, and ultimately this transformation could impact both patient and health center staff and outcomes that were both short, intermediate, and long-term. So now here we are about almost 4 years into this process. And we are already seeing improvements across the health centers, not only with our staff, but for our patients as well. So in the short term, what we really hope to see was that they would be able to take this information and disseminate the knowledge and the tools throughout their health centers and really help their health centers understand this impact of trauma on their patients, their colleagues, and their communities, which is a little piece of what we're going to be talking about today. And then our intermediate outcomes, we really hope to help in creating retention within the workforce. And our data surprisingly ended up showing that we did have a statistically significant increase in workforce retention during that time of COVID when people were actually leaving healthcare. Those who participated in our TSC program actually had retention of staff. And then, of course, our best hope and long-term goal was really to reduce and possibly prevent the impact of some of the most prevalent chronic diseases in our community. So really looking at those improved long-term health outcomes. For example, like diabetes is one of the health outcomes that that are strongly correlated with the adverse childhood experiences. And so we wanted to measure that. Well, what we found out was that our program actually does have a statistical significance in seeing that those that have had out of control, uncontrolled diabetes are now coming under control in that correlation to our program. So we're super excited about this initial data that's coming out about our program and just wanted to share a little bit about about this program. So that way, as we continue our conversation over the next 5 weeks, you kind of have an idea of what we're doing here in Texas. And of course, we're always open to talking about our program and our goals and outcomes with you one-on-one or as a group or whatever. But we just kind of want to lay a little foundation for you so that you would know about the work that we've been doing here in Texas. So why are we talking about trauma, right? So adverse events are really these complex stressors that may disrupt normal development process in each of the biopsychosocial areas. And when that's left untreated, these adverse events really can affect the development of what we call adaptive emotional regulation. So this means the way that our brain functions, the way the individual now interprets actions in their environment, and what they believe and the information that they take in. So and then what happens is often if those things are left untreated, we have this development of maladaptive coping strategies that we can see that emerges. And with all of these things working together really can lead to an increased risk factor for those who have experienced that. And we can see that in risky behaviors, maybe some mental health challenges, and again, that maladaptive coping. So the word trauma really has made its way into a lot of publications, a lot of journals. We even now see it in mainstream media. But trauma is really now becoming kind of common knowledge, something that we're all beginning to talk about. We're really beginning to understand the effects that trauma has on kiddos. And so we really want to make sure that you are acquiring some basic understanding of trauma and maybe begin utilizing some of those trauma-informed care principles that can really allow, if you're in direct patient care, or even for those who do not have direct patient care, maybe you're in a school setting, to begin to recognize that potential consequence that trauma has, but also see the presence of strength and resilience. It's essential that we begin to recognize the root of trauma and really in order to restore that natural resiliency, and eventually turn that knowledge into understanding to be able to promote well-being and health, not just for patients or students, but for families, but also our healthcare system at large or your organizational system at large, which increases community resilience. So what we see is trauma happens when any experience stuns us, maybe it overwhelms us. We may feel helpless or like we've had our feet kind of knocked out from underneath us. It's something really that is experienced or witnessed by us. And so SAMHSA defines that as an event or a series of events or set of circumstances that's experienced or witnessed by an individual and is really interpreted as physically or emotionally harmful. Maybe they even felt like the event was life-threatening or they might lose their life. And then that has a lasting adverse effect on that individual's functioning, whether it's mental, physical, social, emotional, or spiritual. And these traumatic events, a lot of times we can see and we think about our family and social violence. Maybe it's assault, maybe it's disasters, hurricanes, and then even predatory violence that really confront people with such a threat that it may temporarily or even permanently alter the way that they are able to cope. It may affect our natural biological threat perception and even change the way that we begin to view the world and ourselves. So unaddressed trauma can really affect individuals, families, communities, and again, overall health.
So let's move into the types of trauma to review. So acute trauma is a one-time event, so it's usually short-term and recovery is likely. And so examples of that could be automobile accidents, natural disasters such as a flood or a hurricane. Next is chronic trauma, and this is trauma that is repetitive and occurs over an extended period of time. So examples would be domestic violence, childhood abuse, war, and those can even be made up of several instances of acute trauma. So maybe if you are in a disaster-prone area, such as hurricanes, having those happen repeatedly. Complex trauma occurs within specific relationships and contexts, so particularly within trusting relationships, like with a parent or a caregiver. So examples would be abuse or maybe profound neglect. Historical trauma is collective and cumulative. It's multi-generational trauma as a result of systemic oppression and its ongoing effects. So examples would be the Holocaust, the colonization of indigenous peoples. And lastly, systemic trauma. So this occurs within an organization and is kept in place by policies, practices, or procedures. So this can be seen as discrimination, racism, community violence.
So now we're going to begin to look at our body's response when we encounter trauma. When trauma happens, it's more than just that event. It's really what happens to our nervous system. So when those primitive parts of our brain perceive danger, they automatically activate an extraordinary amount of energy. And those are called stress hormones. We talk about them and heard those. Cortisol, especially, is something that we hear about. But when that stress hormone is released, it sparks off the flight, fight, freeze, or fawn response within our brain. And this is a normal response that happens to ensure that all those non-essential tasks that are going on within our bodies are kind of slowed down, and those that we need to prepare our body for that fight or flight response become active. So what could this look like? The body will experience a reduction of blood flow away from our vital organs and into our muscles so that we can be ready to run. Our breathing is going to become fast and shallow, and the production of saliva is going to decrease. Our pupils are going to dilate, so that way we can take in as much information in our surroundings as we can. And something that's very important to know is that our verbal ability actually decreases when we're in fight, flight, freeze, or fawn. So if an individual has experienced trauma, it can be very easy to re-traumatize them if we're providing services and we're not aware, we're not thinking about, or not becoming sensitive to those effects of trauma. So we really want to consider whether we're prioritizing an individual's physical, psychological, emotional, spiritual, and cultural safety while they're in our care. So attuning to safety and maybe creating soothing environments really helps calm this nervous system down and keeps those stress hormones from dumping out into our bodies.
So when an individual does not recognize what is happening within their body as this natural response, it could actually become very frightening for them. And this is especially true when we consider various aspects of a person, including their age, awareness of this information, and even other factors too. So let's review these different responses very quickly. So for those people whose response is the fight, we can see this play out like rage, confrontation, high energy, or actual physical confrontation. For flight responses, we may want to run away from the threat. This can look like panic or anxiety or avoidance. When our bodies perceive that fighting or running away isn't an option, our brains are programmed to freeze and go limp. So freeze can look like shock or numbness, shutting down, disassociation, or even low energy as well. And lastly, we have fawn. So this is appeasing the threat. So we can see this play out as people pleasing, codependency, or even a lack of boundaries that we may see in individuals. So our brain and nervous systems control all of the systems in our bodies, and the nervous system is the first to develop in the womb. But stress is an important component of our conversations about trauma because stress really exists on a continuum. Oftentimes when we hear stress, we may think of it as a bad thing, something that we want to avoid or stay away from. And while that can be true, stress at its core is how our bodies respond to demands or to stressors. And so stress really can look different depending on the context. So typically we think about 3 degrees of stress: positive, tolerable, and toxic. So positive stress or eustress is moderate psychological stress that can actually be beneficial. So it usually motivates us, focuses energy for the short term. We regard things as positive stress if they are perceived to be within our coping strategy or coping abilities. And oftentimes this stress can feel exciting and even performs improvement. So acute or tolerable stress can develop after exposure to one or more traumatic events. And so let's say you were on a hike and you ran into a bear in the woods. That would be very stressful. Our body would start pumping out those hormones like Amy had mentioned. You'd shift into that fight, flight, freeze, or fawn response to protect yourself. And maybe you fought and you got really big and you scared the bear off, or you went into flight and ran away, or maybe you froze and you play dead and you lay down on the ground. But those stress symptoms really develop quickly, but do not really last very long and are mitigated by positive relationships. So having people around us that we can go and say, listen to this story and what just happened to me, they'll be able to help you process that and actually work through the event. However, toxic stress is excessive or prolonged activation of that stress response and is a result of sustained traumatic events or stressors. So if we go back to the bear, what if the bear stuck around, or you had to see the bear every day, or the bear really hurt you? Then it would become toxic and your body would be activated all the time. And so even things that would remind us of a bear, maybe a coat closet or some sort of shadowy structure, would cause our bodies to react and go into that response. So we are constantly in that fight, flight, freeze, or fawn response. And so toxic stress has been found to damage learning, behavior, health across the lifespan. And this toxic stress is when we start to see those adaptive but negative or unhealthy coping skills develop.
So we're going to talk about the brain for just a second here, so hang with us. Science tells us that our brain develops from the bottom up. The base of the brain is developed in the womb first, and that bottom part of the brain really controls our most simple functions, such as breathing, heart rate, blood pressure. At birth, that brain is not quite fully developed, but it continues to develop, and it'll develop, organize, become fully functional. So as that baby develops, the brain really starts to mature and become organized within sequences. They'll sit up before they crawl, right? And then they'll walk. They'll babble, and then they talk. They're moving from the bottom up and working toward building their prefrontal cortex. But there's something very special that's happening and developing in those babies' brains that's going to become very important. They're developing their limbic system, which you can see here on the screen. And they're developing that system in response to all the experiences that they're having around them. They're really beginning to understand when things are scary and when they're fun or when they feel loved. And so the limbic system is part of our brain that really involves our behavioral and emotional responses, especially when it comes to survival. So that limbic system lies right underneath the cerebral cortex and above that brainstem, or that bottom part of the brain. The amygdala and the hippocampus are really two of the major components that we talk about when we talk about the limbic system. The hippocampus comes in a pair, one for each hemisphere of the brain, and it's essentially what we say is the memory center of our brains. So here, all memories are formed, they're kind of cataloged to be filed away for long-term storage. And the hippocampus really helps us associate memories with various senses. So if you smelled gingerbread cookies, you might think of Christmas. If I asked you what is a fruit that is red and shiny and sweet, you probably automatically thought an apple. So those are things that are stored away for long-term storage. The hippocampus is also important for spatial awareness and our ability to navigate the world. And then we have the amygdala. So this is kind of an almond shaped. It's located right next to the hippocampus. It also comes in a pair and plays a central role in our emotional response. So feelings of pleasure or fear or anxiety or anger all come from our amygdala. And then that amygdala attaches that emotional content to our memories, and so plays a huge role in determining how robustly those memories are stored. So memories that are stored with a strong emotional meaning tend to be the ones that stick the most for us. But what we found out as medicine has advanced and technology has advanced, that when an individual experiences trauma, the neuroimaging has really showed us that there is an increased size in the amygdala. Like any muscle group, that if we work something out, it really becomes bigger. That's the same thing for our brain too. So when we have that increased size of the amygdala, it really can begin to inhibit the growth of the brain's gray matter, which is associated with learning and emotional regulation. So our nervous system, under any healthy circumstances, wired to keep us safe, as we've talked about, whenever we face threats. If we were to face a threat, like Aniela said with the bear, our amygdala would take over and either help us enter into that fight, flight, freeze, or fawn. Our learning brain would make a way for survival mechanisms to take place, and that is our normal adaptive response. But when we don't have normal responses, we have this toxic stress that we're in all the time. This is where our brain lives in that state of alarm, where there's our body entering that fight, flight, freeze, or fawn all the time. Then that cortisol is dumped throughout the body. We're preparing to have that response, but this is an ongoing response for us day in and day out. So when you think about stress in our bodies, let's even just think about our muscles for a moment, right? When your body's experiencing stress, like we have a lot of stress at work, our muscles tend to tense up, right? As a way to protect our body from injury or even from pain. That's a normal response. But when an individual experiences an event, those muscles will tense up. And when the crisis has passed, the muscles relax. When an individual experiences that stress day in and day out, those muscles are in a state of arousal and hypervigilance all the time. So this is where our patients in our health centers we may see them suffer from chronic musculoskeletal disorders that may have been activated by an injury, but some of that pain may be our body's response to chronic stress. So prenatally, when mommies are carrying those babies, moms experience a lot of stress. That cortisol is also flooding that baby. In early childhood, we can begin to see that toxic stress can really begin to disrupt organ, tissue, and brain development. So when people are faced with these life-threatening events day in and day out, their primary focus is on survival and self-protection. But that's when we see that survival mode really become maladaptive. Individuals are working from the bottom part of their brain. It might be hard for them to complete tasks. It might be hard for them to keep appointments. It might be hard to understand instructions, or if you're a teacher, it might be some of your students that have a little bit harder time learning. But we really now have a more holistic understanding that this prolonged exposure to stress and trauma can greatly impact an kids' emotional and behavioral development. And thus that need for a trauma-informed care approach to really create support for those who have faced this type of adversity.
So now let's transition into discussing that relationship between stress and trauma and the impact on various aspects of our well-being. So in the late 1990s, a weight loss clinic in San Diego, California made a profound discovery. Dr. Vincent Folletti was a medical provider at Kaiser Permanente. He was approached by the organization to develop a weight loss clinic. He agreed, had instant success with individuals losing 100, 200, 300 pounds. But then he started having those that were the most successful start to drop out of the program and even start to regain the weight, sometimes incredibly quickly. And the first of many unexpected discoveries was that the majority of patients who dropped out actually were successfully losing that weight. And so accidentally, and to the surprise of Dr. Folletti, they learned from detailed life interviews of over 286 individuals that child abuse was remarkably common. And if it was present, it was always a springboard or the onset of that obesity. And so for many, the obesity was not the problem, but it was the protective solution to problems that they previously had not acknowledged to anyone else. So the adverse childhood events or experiences, or ACEs study, and subsequent research has found profound and powerful connections that include both physical and mental health outcomes, including the development of chronic conditions, and the major causes of adult mortality in the United States, alcohol and drug abuse, diminishment of lifetime opportunities regarding education, occupation, and income. So for the first time, researchers really correlated the bad things that happen to individuals in childhood with long-term impacts across their lifespan. Originally, the original ACEs study had 10 types of childhood trauma that were measured. 5 were experienced directly by the individual, and 5 were related to a family member to their household. Each individual trauma counted as 1, and so an individual could have an ACE score between 0 and 10. And the important thing to remember is that researchers have consistently found that the higher the ACE score, the higher the likelihood of at least one of those negative outcomes. And the type of trauma did not factor into that score. So unfortunately, ACEs are highly prevalent. Current data from the CDC shows that about 61% of US adults report that to have at least one of those ACEs, and 1 in 6 report to have 4 or more. ACEs affect all communities. So the original ACEs study was done among a population that was mostly white, middle class, employed, college educated, and privately insured. And so subsequent studies have found higher rates of prevalence of ACEs among individuals experiencing poverty, people from racial and ethnic minority groups, people who are incarcerated, and individuals in the LGBTQ plus communities. So I want to call your attention to the bottom 2 sections of this pyramid. So the historical trauma and cultural and social conditions of trauma. So we know that trauma can be passed on, and historical trauma impacts populations that have experienced collective, long-term, and widespread adversity over generations. And this can look like slavery, segregation, racism, violent colonization, and genocide. We also know that social and environmental factors such as community violence, structural oppression and racism, chronic poverty, and forced displacement are also traumatic experiences. And these are the structural institutionalized systems that affect the well-being of individuals over the long term. So I want to then call your attention to that to the next step up, which is those social conditions or the local context. So those are the places and spaces where we live, work, play, love, die. So this all all is structured together. And subsequent studies have actually started adding in experiencing bullying, witnessing violence, experience with discrimination and racism, involvement in the foster care system, living in poverty, and then those experiences with deportation and immigration as well. And lastly, ACEs are strongly correlated in a dose-response fashion with some of the most common and serious health conditions facing society today. So we finally have evidence, like we mentioned, that what happened to you as a kid does have a very real impact on the quality of life. We see that with our patients, we see that with ourselves, we see that with our communities. We see trauma survivors may smoke cigarettes or drink alcohol or overeat to manage emotional distress. But even though those behaviors may provide short-term improvements, really those long-term negative outcomes and consequences are very, very real. So we will discuss this in our series, but some outcomes that are highly correlated with persons with a history of trauma include alcohol, tobacco, and drug addiction, chronic obstructive pulmonary disease and ischemic heart disease, diabetes, lung cancer, obesity, self-regulation and anger management problems, and then work problems, including absenteeism, productivity, and even on-the-job injury.
So you might be asking, why are we focusing the majority of our conversation on the childhood years and these adverse events? Well, during childhood years, those are really those building blocks that set the stage for how individuals will manage adult relationships, behaviors, health, and social outcomes throughout their lifespan. So we know that while some degree of stress is good, as we talked about, that exposure to that long-term stress and the absence of protective factors is where we see that toxic stress kind of rear its ugly head, and at a basic level causes harm to our nervous system, our endocrine system, and our immune systems, even maybe altering the structure of our DNA. So changes in the brain from that toxic stress really can affect such things as attention, impulse behavior, decision-making, emotions, how we respond to stress as adults. So in the absence of protective factors that can prevent or even reduce that toxic stress, kiddos growing up experiencing toxic stress often struggle to learn. They're at increased risk of becoming involved in crime and violence. They're increased risk of using substances as a way to cope. They're engaging in other health risk behaviors like maybe the early initiation of sexual activity, unprotected sex, and even an increase in suicidal attempts. Individuals are susceptible to more disease and illness, mental health challenges over their lifetimes. And this graphic here comes from the CDC. So we talked about having difficulty forming those healthy and stable relationships for individuals who are experiencing toxic stress. They also may have unstable work histories as adults. They may struggle with finances and family and jobs and depression throughout their life. All of these are effects that can be passed down to their own children. And again, it's important to note that the higher that ACEs is, of course, we see that higher negative health outcomes. And they've been associated with 40 such outcomes, including the health risk here that you can see on your screen, chronic health conditions, infectious disease, limited educational and economic opportunities, and of course, as Aniela just talked about, that early death.
So as we discussed, and we know that adversity is potentially interrelated. So one compounds on another, or in many of these situations exist simultaneously. Initially, we thought that the start of childhood trauma was the start for individuals, and then we build up from there. But as you saw in the previous pyramid, and you can see in this slide, we really know that it starts historically and in experiences that have happened in individuals past, whether it's culturally, societally, intergenerationally. That can build up into our non-medical drivers or SDOH. It is progressive, and so these things build on one another. These things are often predictable. So if you learn about cases or think about patients or clients that you work with, and they tell you their story, you may be able to see in the future, I have a very good picture of what could potentially happen down the road. So what happens if we can get ahead of these various things and be preventive in our care and our engagements in society? These things affect our relational health, so how we interpersonally relate, but then in our workplaces, and create challenges ultimately for workforce development and ultimate lifetime opportunity for individuals. Then we have those ACEs happen because if our parents are stressed, maybe this plays out with the relationships with their kiddos, and it goes vice versa. We see social, emotional, and intellectual challenges. This again plays into those early adoption of maladaptive coping strategies, and then it just creates that really cycle, and it goes around in the wheel. So again, we don't want this to be destiny, and so this is why we are very excited to be with you today to really talk about now what can we do to prevent the cycle from continuing.
Yes, that was deep and heavy. And so now let's think about what we can do to have those strategies for healing. So really, trauma-informed care is this strength-based framework that really understands and responds to that impact of trauma. We want to have physical, psychological, and emotional safety for all those individuals who've experienced trauma, and really begin to create the opportunity for them to rebuild a sense of control and an empowerment. So being trauma-informed is really a philosophy and systematic framework, the way we truly see people and we honor their humanity. It's a lifelong commitment to culturally affirming, compassionate, and inclusive practices that avoid re-traumatization. It really helps us to empathetically hold a safe space, and it allows every interaction to be a powerful reminder that people are the experts in their own lives. And so really having this fundamental approach and this shift in our culture of an entire organization, it's not enough for us to just know about trauma and to be able to identify it and respond to it, but definitely in the not re-traumatizing individuals that we come in contact with. So here are the trauma-informed care principles. This is what we work with all of our health centers to really ground in and have an understanding of as they move forward. So I won't go through all of these just for time's sake, but really when we're thinking about safety, we're looking that throughout the organization, staff and the people that they serve really feel physically, psychologically, morally, spiritually, and culturally safe. When we think about trust, the organizational operations and decisions are really conducted with transparency in order to build and maintain trust amongst staff, individuals, and family members of those who are receiving services. And then thinking about those historical, cultural, and gender factors, we really want to see organizations actively move past cultural stereotypes and biases and offer culturally responsive services. So really leveraging the healing value of traditional culture connections and recognizing and addressing historical trauma within the organization.
So as Amy mentioned, trauma-informed care is really an approach that grew out of an awareness that sometimes traditional approaches do not work, and many people have experienced trauma, and they often have a lasting impact on the individual. So TIC recognizes this pervasiveness and emphasizes the importance of interactions based on those pillars. It really shifts kind of quintessentially from asking what is wrong with you as a person, as a community, as a society, to what happened that is causing this behavior that we're seeing, or these interactions that we're seeing. Our health centers, our behavioral health organizations, our community-based organizations that you all represent often see people when they're at their most vulnerable, when individuals need help, when they might feel unsafe or disempowered. And so it's important to recognize the role of power dynamics that are at play when pursuing more equitable trauma-informed practices. And we'll be talking more about this as we move forward with the series as well.
So for our program, we have 6 key strategies that we use to really foster that healing and hope. And you can see those 6 listed, and we're going to talk about each one of those really quickly here.
So as we described at the very beginning, the application of universal trauma precautions means that our policies, our practices, our procedures are crafted under the assumption that all individuals may have experienced trauma. And when we engage with everyone in a way that prioritizes care and compassion as a result. So if you kind of think about the universal precautions where we don our gloves and everyone really assumes that all individuals seeking services may have been exposed to those negative conditions. So this really is the same way that we want to include and create our environments that we are really looking at symptoms and behaviors in a different way, and that we are using a different lens to create safety for individuals. So as we mentioned earlier, with such a large prevalence of trauma across society, and even more so among individuals that we serve within our health centers and our behavioral health organizations, the necessity for this approach is really clear. So just as we take these precautions in medical settings, the same applies with trauma as well.
We really want to use a strength-based approach. This really empowers and provides hope to that individual that you're working with. We want to provide psychoeducation about what trauma is and what trauma responses are. Many times people don't even have the understanding of, oh, I'm having a trauma response and it was activated by something that just happened. So explaining how our bodies biologically can really kind of take over our cognitive thinking. So if you have somebody that's sitting in your waiting room and something happens, they get activated or startled, that experience really may have them drop down into that bottom part of their brain where the amygdala takes over, right? And this is a false alarm. It sets our bodies up to reacting and dropping down into that bottom part of the brain where we are entering fight, flight, freeze, or fawn as a response. And so we want to be able to say, oh, okay, I'm experiencing fight, flight, freeze. I want to run out of this office right now. It helps us to calm down and come back to the top part of our brain. So using that strength-based approach is really a trauma-informed approach as it actualizes that principle of collaboration.
So a way to engage in trauma-informed work is through the practice of cultural humility. So this is really that move from cultural competence that we are confirmed. I know and understand the various cultures of populations that I see, to a humble approach where I am taking on a lifelong commitment to constantly evaluating my own self, my biases, my practices, that I'm incorporating and willingly welcoming feedback from other people to with regards to power imbalances or how various relationships play out, or what I said or how I said it, or in those engagements. So it is this lifelong approach. Cultural humility really emphasizes a particular orientation, so rather a way of being rather than that mastery of skills as we previously had been trained with cultural competence. Cultural humility is fully aligned with trauma-informed care and patient-centered practice. So really from the beginning of any engagement, establishing relationships with others based on collaboration and respect, understanding the prevalence of historical and systemic trauma can foster a respect for individuals over time, and knowing that those relationships may take time to develop. Regarding the patient and the client and the community or the coworker as the expert in their life and their story and their experience, And humility and a genuine process of self-reflection is really critical to ensuring that we minimize that traumatization for individuals and others.
So whether you are in a school setting, a healthcare setting, maybe you work at the bank, interventions that we have are really connecting supports and resources that are designed to be sensitive to the presence and symptoms of trauma is one of those ways that we really focus in our trauma-informed care program. If you're in healthcare, this might include providing referrals to providers who really are best able to help your patients at every stage of their treatment. But not all trauma requires behavioral health. So this might include providing patients with referrals to additional services beyond therapy, such as medication management, social support services. This might be, talking about sleep hygiene or nutrition. So really thinking about what are those trauma-informed supports that we have, what can we develop, who can we partner with that can provide these type of interventions for those who've experienced trauma.
So minimizing re-traumatization. This has been discussed throughout the course of our session today. So transforming our organizations to ones that are safe and can reduce re-traumatization is the ultimate goal. So we want to use those pillars that we discussed earlier, embed them in our work. So that way, when our patients or staff demonstrate trauma symptoms or are activated, they know that they're in a place of protection and hope and recovery and not ones of judgment or shame and blame. If psychoeducation is provided to the patient and they become aware of what activates them, then and what keeps them safe, then that rapport and that relationship is even further extended. It may even be easier for them to help transition to finding other more effective means of coping as well, if we're really working on empowering them in that education. Trauma should not be processed, though, until the patient has sufficient coping skills and stabilization. So we know that there's a lot of folks here within our mental behavioral health colleagues. So knowing that we're asking and potentially screening very intentionally and with a very well thought out process to reduce the risk of re-traumatization. But forcing the patient to move forward with a trauma narrative or going beyond that trauma wall before the patient is ready really can potentially cause harm to the patient.
So we began out at the top of the hour really acknowledging the necessity for self-care due to this topic. However, we know that engaging in trauma-informed care implementation also leaves us needing to have some self-care for ourselves as professionals as we work with individuals who have experienced trauma. So there is a need for us to take care of ourselves as well. We're not immune to the effects of trauma. We have our own lived experiences that we come to the table with. So for those of you who are in the helping profession, we know that distress can lead to burnout. And distress is that perception with a negative or unwelcome outcomes. So some examples of distress maybe could include hearing stories about pain and suffering and trauma from your patients or your clients and not being able to do anything about it. Maybe it's having somebody's story connect with the story from our past, or maybe it's encountering organizational, societal, or political constraints that really prevent us from implementing some evidence-based services. And then of course, work demands that really seem like they never decrease. So unfortunately, chronic work stress really impacts people and organizations in very real and sometimes in extreme and serious ways. And so the implementation of trauma-informed care really can impact organizations, can help them to prioritize all aspects of workforce well-being, since we know that poorly managed distress levels rob individuals of that cognitive, medical, mental, and social health that they need to success and really enjoy work and life. So burnout causes teams and organizations to operate typically below their potential while opening them up to various risks. So practicing self-care or putting on your own oxygen mask first, as they say on an airplane, is a requirement. But organizational support to workforce well-being is also a necessity. So being trauma-informed means that you're really kind of creating this caring, compassionate, and safe space, not only for individuals that you serve, but also for the staff that serve with them as well.